Thank you, Mr. Chairman. It's really going to be a talk on lack of equipoise. I've declared my conflicts of interest before. This is the 24 countries of the OECD looking at the relative rates of cabbage to PCI. You can see that the median is 3.29, but the range goes from 0.67 up to 8.63. So I guess currently in 2010, the surgeons having the hardest time are in Spain. So not just their economy. This is what's happening in Ontario in Canada, and it looks at 17 hospitals doing PCI in cabbage, serving the same geographical area and population. And you can see that the rates of PCI to cabbage vary from just over 1 to almost six-fold difference within the same population. It also interestingly points out in this paper that only 4% of all of these patients were ever discussed at a multidisciplinary team meeting. And not surprisingly, it's in those hospitals doing the highest rates of PCI where you have least chance of getting bypass grafting. Now, we talked earlier about the UK and that we're not as bad as the North Americans. Well, I'm afraid to tell you, we certainly are, if not worse. And this is a piece of work done by one of my very bright medical students in Oxford, and he's going to present the full paper tomorrow. But what it shows are the ratio of elective PCI to cabbage per 100,000 of population. And the medical student he got all the data from 151 PCTs to get this correct. And what you can see is that the median ratio is 1.2, but it goes from a minimum of 0.36 up to 4.74. So within the United Kingdom, a 13-fold difference between the lowest and the highest performing PCTs. And the really striking fact is that these two PCTs, the one at 0.36 and the one at 4.74, are 40 miles apart. Now, how you can have this discrepancy in the ratio of PCI to cabbage in a so-called National Health Service, what it tells you is that a lot of the variation in this is unwarranted. So what's happening in terms of PCI cabbage ratios is being driven by non-medical considerations. This is a paper I also mentioned earlier by Martin Yates working with Marjan Jahangiri, which I showed just to illustrate the point that in the 6 months before and 6 months after the publication of guidelines, there's been no real change in practice, at least in St. George's Hospital. Now, why do we see what's going on? And again, I wish David Hildick-Smith was here to see this, because this is another review done by one of my, another very bright medical student, who looked through the literature at all the papers looking at informed consent, both for PCI and cabbage. And he identified 10 studies involving about 1,500 patients, of whom over 1,000 were PCI and 440 cabbages. So these patients were written to after they had undergone the intervention, and they were asked why do they think they had received the intervention. Now, if you look at, cabbage is in blue, that's right, the pink is in PCI, it's disappeared off the slide. But in terms of improvement of angina, extension of life expectancy, prevention of MI, and whether patients were offered alternative treatments. And what you can see is that almost 70% of patients undergoing PCI said that it would either extend their life and prevent myocardial infarction. That's what they claim was the main reason they'd had this intervention. Yet we know PCI does neither of these things. If you look at in terms of who was offered alternative treatments, well, almost 70% of the cabbage patients were, and only 15% of patients undergoing PCI for multivessel disease. So when you look at this and you realize that 70% of PCI patients have had an intervention which will change their life forever, but they've failed to understand why they were having the procedure, that is a scale of misconception of why patients are agreeing to interventions. If you look at the National Cardiovascular Registry data in the United States between 2009 and 2010, it looked at 500,000 PCIs in 1,000 US hospitals. And when it looked at the 29% of patients who were non-acute, in only 50% of them could they find an appropriate reason for having done PCI. In 38%, it was either uncertain, and in 12%, it was inappropriate. And if you look at the reasons it was inappropriate, it was either patients had no angina, no ischemia testing, or suboptimal medication. Now, the median rate of inappropriate PCI in these 1,000 hospitals was 11%, but it ranged from 0 to 55% of all interventions. I showed you this earlier about when you don't have heart teams and guidelines, this is what happens. Even if you've got class 1 indication for CABG, only half the patients will get it, whereas if you have class 1 indications for PCI, 94% will get it. Now, to address that paper was an editorial by Ray Gibbons, former president of the American Heart Association, and he asked why was there such a discrepancy in what was happening with these patients. And he said, a final potential explanation, and in my view the most concerning, is that these recommendations for PCI in patients indicated for CABG reflect a grow the business and make it up in volume mentality in response to declining reimbursement rates. There are compelling financial incentives for cardiologists performing intervention to do more procedures even when the patient might be better treated with CABG. Now, this is the ex-president of the American Heart Association. And he goes on to say, should surgical consultation be encouraged as suggested by the authors? There are many patients with stable symptoms for whom issues of contrast load and the need for further discussion with the patient dictate that PCI is performed on a different day. But he concludes, in such patients, surgical consultation should be considered, but not mandated. But then, if you go back to what he said previously, there are compelling financial incentives for cardiologists performing intervention to do more procedures, even when the patient might be better treated with CABG. I've shown you these recommendations before in what we should be doing with patients. I've emphasized that 79% of all 3 vessel disease and 2/3 of all left main are class 1 indications for CABG and class 3 for PCI. So if I summarize and conclude, today 2/3 of all left main and 80% of 3 vessel disease have strong survival advantage with CABG. It's apparent at 3 years, and it continues to increase past 5 years. And as I'll show you this afternoon, when you look at 5 years, the survival curves are still actively diverging, suggesting that the benefits of CABG may be underestimated even in the 5-year results of Syntax. There are very large variations in the PCI CABG ratios between countries with similar economies and within different regions of the same country, and that does include, most definitely, the United Kingdom. There is overwhelming evidence that the absence of the heart team, following approved guidelines, results both in the majority of elective PCI patients failing to understand the rationale for the procedure and also a large number of inappropriate or wrong interventions. Guidelines are transparent and protect the patients against the wrong interventions, and they also protect the interests of doctors by ensuring that patients get treated correctly, and I believe they should be mandatory. I would finally say again that professional bodies should persuade the statutory bodies or payers that they should only pay for interventions which are approved by the heart team based on official guidelines or documented as to why guidelines were not followed. The conflicts of interest for practitioners are so perverse and so enormous that there is no chance of medicine getting it right for patients. I don't think there is. I think we've got to involve statutory bodies who ensure that doctors do the right thing. On that point, I'm going to conclude my talk, and again, thank you for your attention.